Good morning. How is everybody? It is healthcare today. I'm going to try to share my screen. This is my daily comedy routine, which the old guy tried to work the screen share. Hopefully you're seeing that. This is a 2021 National Healthcare Summit. This is something new for us at RE Journals, Minnesota Real Estate Journal, Illinois Real Estate Journal, Red News, all our publications. And we're doing national events now. We're going to keep these going after COVID. So once we can get live in event venues, we're excited to be there. We're going to continue to broadcast those. But we really found a special niche, I think, that we can have an event that we broadcast nationwide of national relevance. So sometimes healthcare real estate is local. And what are the local things happening? I know we got Bruce Nordquist talk about some local stuff on this panel coming up, but also what's of national importance. So we can expand the topic and bring in national speakers from around the country. So we're really excited about this platform. We're doing one a month, and this is like our third or fourth one. So thank you for joining us. Hopefully you enjoy the platform. We're going to continue to do it. Special thanks to all these sponsors. So if we were to rewind to last March when I was on spring break, I almost passed out when I found out we weren't going to be able to hold live events anymore. And I thought it was just going to be for a few weeks, and turns out for it's a long time. So without sponsors like this, we couldn't have pivoted to an online environment. This took an enormous amount of resources, work, and pivoting on our team's part. So without this, we wouldn't have been able to happen. So special thanks to all of these folks for helping us create really unique, interesting online environment. Even though we can't network, we can sit and still learn information from each other. In case you didn't know, this is us, RE Journals. We have 6 publications, 17 states, we do about 150 events a year. This first panel, before I go to this panel, let me just show you something really special here. This is our virtual lobby, and you saw this because this is how you got to this event. You clicked on this watch event here button. But what I want to point out to you is that all of these speakers, their headshots are here. You can find out more information about them and connect with them. So this is the little bit of networking you can do in the online environment, is to click on this little LinkedIn button right here, and you can connect with these folks on LinkedIn. You can also see what they're going to talk about, and you can see who's sponsored and learn a little bit more about those sponsor companies at the bottom. So there's our 2 panels. All right, last but not least point, and then Chantily, I'm turning it over to you. The chat room, okay? Everybody watching online, open up your chat rooms right now. I'm going to say hi in here. There's a trick to this. There's a drop-down menu. You have to choose 2 all panelists and attendees so everybody can see it. I'm going to go in there, and I just said hi, so you probably saw it pop up on your screen. Grab that. And I'm going to ask you a question, okay? This is a poll question. And we have a lot of folks from my home state of Minnesota on today. So I want to ask you this. Minnesota Twins. How many fans do you think will be at the first Minnesota Twins game this year? Season opener. How many fans? 0, 10,000, full stadium, whatever you think it's going to be. So go in that chat room, please answer that question, and appreciate that. Chantilly, it's all yours. I'm going to log. I'll still be here. You won't see my camera or microphone, but if you need me, say, hey, Todd, but I think you guys are all good to go. I'll be back in an hour. Thanks.
That sounds great. Thank you, Todd, so much for the introduction, and thank you, Real Estate Journal, for hosting today's summit. Before we dive in, just to reiterate, any questions that come through during our session, I will try to monitor. Our panelists will also try to monitor as well, so that we can help answer those questions as we can during the panel. If we don't get to your question, time permitting, we'll certainly review the questions in the chat box and field those questions then. Now, before we dive in, I wanted to give our panelists, Hilary, Erin, Angela, Bruce, and Connor, a chance to share more about their background and their expertise in the healthcare and life sciences sector. And so let's start with Hilary. If you could give your introduction, that'd be great.
Sure, thank you. Thanks for having me. My name is Hilary Blair. I'm an administrator at Mayo Clinic, and my background is in laboratories. I originally started as a cytogenetic technologist way back when, and have worked through different roles at Mayo Clinic, and eventually became an administrator very recently. The reason that I'm participating on this panel is that we are working on building the Anna Maria and Stephen Kellen Research Building at Mayo Clinic. And so I am part of a team that is leading the programming for the building, as well as oversight of the building itself.
Wonderful. Thank you, Hilary. Erin, let's go to you.
Thank you. Good morning, everyone. 7 o'clock here at the West Coast where I reside. I'm Erin Couch. I am the Architectural Standards and Design Director for Providence Health. We are a 7-state 51 hospital and over 1,000 clinic healthcare system, Catholic faith-based, on the West Coast. And in my role, I not only serve to update our standards and deploy them across our system, my more important role actually, as a healthcare architect myself professionally, is to advise on our project design work across our 7 states. And I also serve on our planning council, which looks at strategy, land use, and design across that same region. So thank you, and glad to be here.
Thank you, Erin. Angela, let's pivot to you.
Yeah. Thanks for having me. It's a nice morning here in Minneapolis. So I'm an interior designer by education and trade. I work for BDH. We're a local design architecture firm here in Minneapolis, but our reach is broad. We're locally based, but we work nationally across the entire country. My expertise, my 20-year career has been solely focused in healthcare design and the furtherment of partnering with our clients to meet and develop flexible environments that are going to meet the needs of today, but also try to plan for the future, really the unknown. So that's a fun part of my conversation. So
I love it, Angela.
Thanks.
Bruce.
Well, hi, good morning. I'm the Community Development Director here in Apple Valley, Minnesota, a third-ring south suburb of the Twin Cities, a suburb of 55,000 people. And I'm in the business of attraction, retention, and expansion of business. I've been doing it for 40 years and with 14 of those in Apple Valley.
Wonderful. Thank you, Bruce. And Connor.
Yes, thanks for having me. I'm Connor Lewis. I'm the National Vice President of Healthcare Development with Ryan Companies, Ryan Healthcare. I'm going to apologize for that photo. It's one of my least favorite photos. I'm just going to say that. I call it the fat head. I don't feel my head's that big. I grew the beard to hide that. So this is what I look like now, not so much the big fat head on the screen. I've been with Ryan for 7 years. I develop projects literally coast to coast across the United States of all project types and mixed uses, but all around healthcare. So a big fan of this opportunity. So thank you so much.
Wonderful. Thank you, Connor. And I am your moderator, Chantily Malibago. When not moderating scintillating panel discussions like this, I'm responsible for leading Mortensen's healthcare development vertical. As some of you know, Mortensen is a national provider of integrated real estate development and construction solutions. We have a deep history serving our health and life science communities with over 190 relationships with health systems, academic medical centers, and care organizations providing real estate development and construction solutions so that we can help advance our healthcare ecosystem. All right, let's get started. And I wanted to provide a little context for our audience members. You know, we are in unique times, and the pandemic has strained our healthcare ecosystem, spotlighting weak points and opportunities within our communities, within our infrastructure, and within our supply chain. And we saw this early on with a shortage of personal protective equipment, to the race to an effective vaccine and its distribution across communities. The pandemic has also highlighted the conversation around determinants of health, exposing the inequities in health access as data is pointing us to certain communities and people with certain health conditions becoming more disproportionately impacted by the virus. Furthermore, the pandemic has accelerated shifts in care delivery that were already in motion pre-pandemic in response to ongoing threats, such as the large aging demographic, changing consumer preferences, the shift to value, as well as the integration of technology-enabled care by some providers. This acceleration is translating into changes that are becoming more of a permanent part of our care delivery model, such as the broader adoption of telehealth that's been enabled by subsequent policy shifts by CMS and payers to expand coverage for virtual care, or a focus on digital technology such as AI and the automation to aid diagnoses, treatment, anticipate outcomes, drive utilization, and engagement. Now, these factors, coupled with the economic fallout caused by the pandemic and its subsequent financial impact to our healthcare sector, as well as priorities of a new presidential administration, means this: we are in the midst of an accelerated transformation of care. And so today, I'm very excited about how we will look at these shifts and how they are impacting our healthcare ecosystem, specifically from this group of panelists, the brick and mortar infrastructure, the real estate, supporting the environments needed for research and development of treatments and medical technology, as well as the environments needed to create healthier communities. And so our panel of experts will be discussing the strategies health systems and other organizations are taking to adapt and adopt to a new normal, to future-proof and quickly adapt against a changing environment, as well as discuss how the supporting community, how developers are playing a role in creating these healthier communities. And so with that, let's start with the care delivery side of the discussion first. And I'll go to Erin. Erin, you are experiencing closely the coalescence of impacts to patient care delivery. Talk to us about how these and other factors are impacting your system's care delivery strategy and how this strategy translates into real estate and design. And as you tackle this question, maybe, for context, tell us more about Providence Health.
Sure. Well, Chantily, if you keep going, man, I'm telling you, you've got this down. I don't know why I'm here because you've just hit all of our hot topics here at Providence. So thank you for that. I didn't know if you wanted to share slides or not, or okay, great. So let's look into that because I'm not sure this audience actually knows much about Providence because we are on the West Coast, or not. We don't have to share them. There you go. So that's me. You can go to the next one. Although I will say I am a Duck, so go Ducks, University of Oregon. I'm just going to leave that there. So again, Providence was founded in 1865 on the West Coast by the Sisters of Providence, who had they'd gone transatlantic down through the canal and on up. Well, there was no canal, so they went around the Horn, all the way up to the West Coast from Montreal to establish a healthcare system in the West. So you can go to the next slide. Our mission is the things that you see here. We are Catholic based and we are nonprofit. We've seen a lot of change this past year, but our mission stays true that we want to deliver care and to those who are poor and vulnerable. Next slide, please. So here's just a real brief look at the states we cover here in the Pacific Northwest, Southwest, and of course, Alaska. We are known by many different healthcare companies. There's Covenant in Texas, Swedish in Washington, Facey in California, and Cadillac in the Tri-City area of Washington State. And of course, every leader of our system, Dr. Hockman, who was a geriatric specialist, nailed it, right? We are big and we are small. Our bigness has actually helped us during the pandemic, as you might expect to some of our smaller regions. But we're very small. We can be very small delivery care in some of our regions. We have critical access hospitals and other facilities. Those are some of our other brands. Again, just a little more slide showing the largesse of our system. I point out 51 hospitals. Boy, do we know how to buy them. Sometimes we acquire these hospital systems whose facilities are less than ideal. So we'll have a little discussion about that later. And then lastly, the focus here, I know, what is this diagram? The one you need to focus on is the one on the right. Really, healthcare for years has all been about us getting you to our hospitals. Yay, we want your money. No, well, we want to keep you healthy, but there's a total shift, and it really happened in, at the beginning of the Affordable Care Act, is now we are, not only are we won't get paid if we don't keep you healthy. That's a huge hit, and rightly so, by the way. But mostly we want to focus on you, the patient, and how to actually keep you away from our acute care facilities, because that is becoming a much more specialized institution as we move forward. So I think that's the last one, Chantily. And if it isn't, it should be. You can get rid of that one. That's enough. That's enough Providence for you. But one of the things that Chantily hit on many targets for Providence that do affect Providence. And since this is a real estate audience, I will say that real estate is going to see some very interesting changes as we move forward. COVID absolutely devastated us when it came to visits at our clinics and our hospitals. So yes, we have a very robust telehealth visitation schedule. Now that it's kind of panned down, it's more like 20 to 30% of visits now are telehealth visits. And that will probably decline even more as people get vaccinated and become less worried about getting COVID. So that's nice. But it's really opened our, and by the way, in case you probably hadn't heard or read, we aren't getting paid a lot this past year because nobody's coming in to get those elective surgeries this year. So yes, we did get reimbursement from the federal government through our CARES Act, and that has helped support our ministry. But on the average across 51 hospitals, you may expect that CARES money was much less than you might think per facility. And that's okay. Providence is very fortunate in that we have other income generating avenues, mostly in our tech side that we sell to outside agencies. That's another discussion. But I do want to focus on the fact that we have really had to look and relook at how we deploy health. And I know that we can have a more robust conversation about this later, but certainly in this market, we are looking at properties we probably wouldn't have thought about before. For example, did you know that you can do something like 15 different procedures and exams from your shoulders up in a car? Oh no. So it's not just the happy car that, gets you your vaccine and yes, I have been vaccinated. That is a perk, by the way, of working for a healthcare system. But it's not just vaccinations, it's taking care of kids in a car. It's looking at your elder father who needs just needs to have his heart checked out. So we're looking at properties such as banks, like, oh, hey, can we borrow that drive-through? And what about that pneumatic tube? Can we, we're not going to have you, we really aren't at the point of healthcare where we have you draw your own blood and put it in a tube and send it through the pneumatic tube. Okay, we're not there. So don't worry about that. But there are these technologies that are inherent in some properties that are like, we're looking at like, we could do triage there, right? Set up a screen. You're already talking to it because there's a speaker there. Why aren't we looking at some of these properties for that? And so that's kind of been a real shift for a healthcare system, which may or may not have an analogy of being like the Titanic in that it takes us forever to turn the boat. But boy, has the pandemic really shifted our focus on other types of care delivery. The other thing I'll mention briefly, and I know Angela would probably dearly like to speak, so I'll cut here. We're really having to repurpose the use of some of our clinic spaces. That's been really useful. So we have many different types: express care, urgent care, clinics, more traditional healthcare. But the express cares, because they're only 2-room facilities, those ended up being perfect for COVID testing. Who knew? You're going to hear a lot of words like flexibility and future thinking, and that's absolutely correct. Why we weren't thinking those terms 30, 40 years ago not 40, 30 years ago when I was a young architect is beyond me, but really those are keywords going forward. And thank you for the opening statement, and I will turn this over to Angela.
Angela, now that you work on the kind of service side, the supporting customers like Erin, what are you seeing on your end? And maybe, again, for context, if you would like to provide a little more context around your organization.
Sure. Yeah. So like I had mentioned, I'm locally here in Minneapolis. I am part of a design firm that provides architectural interior design services, comprehensive services. We've been in business for 50 years. We're celebrating our 50th year in December. And we do work not only locally, regionally, but we also work across the country. We've worked in all 50 states. You can see there where we've got current projects and current licensures in the indicated states. Really what we focus on, we're a multifaceted design firm where we specialize in healthcare, housing, and workplace corporate. I specialize in healthcare, and we're really focused on creating transformative design for healing and being a true partner with our clients, our health systems. And it's not only the end users that we partner with, it's also our contractors, it's the real estate brokers. We view ourselves as one part of a larger team to be the success. I think the other thing too is we use our design as our tool to create these environments that make life better and have aspirations that are possible for all. And it's not just one sector, it's for the entire community. This last year has been, wow, it has been an amazing journey that we've all been on in some sort of fashion. I've been working as a designer in healthcare for over 20 years now. And I would say this last year, all the things that we've been talking about and beating our drum and partnering with our clients, it's really coming to fruition. It's not, we should do more telehealth. It's, we're doing more telehealth, and these are the lessons that we're learning. In terms of evolution of design and how we are partnering with our clients, it's this, as Erin touched on it, it's this shift to wellness. And it's not, it's now we're moving to a proactive stance on healthcare. And there's a shift in our culture to have a little bit more responsibility of our own health and to avoid going to the hospital. What can I do? I know I need to sleep and take my vitamins and eat whole foods and exercise when I can to make myself better, physically stronger, healthier, mentally strong. I think we've all been challenged in every facet of everyone's lives, both personally and professionally. And where healthcare design is transitioning to is supporting of that. And there are adaptations to the design environment, the built environment that really support that wellness shift. I think another key thing is lean process and lean design. This is not a new concept. This is around for decades. And health systems are adapting to it. We all are challenged, whatever facet of the industry you're in, we're all challenged to become more efficient, do things in a lean process, especially from a healthcare provider. You need to get your PPE from point A to point B with the least amount of obstacles in the way. You need to gather and harness your data that you're collecting in your electronic medical record systems to help inform with the built design environment. Partnering, being a strategic partner with our clients too, as Erin mentioned, like virtual care, telehealth and telemedicine has really been adopted because of the barrier that COVID had caused us. We couldn't get together, but that doesn't mean our care deliverable is negated. It doesn't mean we can't still provide care. And using that technology, there's, when we talk about like outpatient healthcare centers, there's a real shift to become flexible, adaptable for the ever flowing, as I call it, of the pandemic. Some days we're going to be at a more heightened level of alertness, I should say, where we need to really look at our HVAC systems. How can we better provide more air filtrations, more outside air exchanges? How can we install more MERV filtration systems within the HVAC system? Those are simple things. And then it comes down to, how do I function in my exam room where it's a built environment for one-on-one in-person care? But now I'm going to be shifting to telehealth. What do I need to do to improve that? Is it the acoustics? Is it the lighting? Do I have the right IT equipment? I think another big thing that we have to point out and talk about is security. Not only for security from a safety standpoint, you know, we've lived through just recently here in Minnesota with a recent shooting in a healthcare clinic in a rural setting right outside Minneapolis. It's very devastating to hear. And I know other events like that have happened throughout. Safety is another big key when we're designing facilities. Security from an IT standpoint, making sure that the IT systems are a robust system to protect that data that we're gathering and using to help inform design decisions. The other thing that I kind of want to add is from a design arm, there's so many challenges of how you create a clinic or a healthcare environment that is a flexible and adaptable environment. That's such a big task to undertake. And it's not just one sole design team member that's going to be able to solve that problem or to solve that issue. It's really part of the entire design team. And that entire design team includes the healthcare system or the private practice and their strategic business model and their strategic plan of where they need to provide care, how they're going to be providing care, and what areas need to be flexible and adaptable. It's partner with the real estate brokers to making sure that we're getting into a space like Erin had mentioned. Hey, are we taking a look at banks because we could use this as a triage center? Are we looking at retail that has been vacated, but it's in a great location that's close to the community that we're serving, and it's right next to, next to the grocery store. So it's in a very centralized location. It's those creative thought processes and partnerships that really create a true robust solve to the part of the equation. General contractors as well to help us keep us on track with the budget is another key team member. As Erin had mentioned, the whole industry, we are just our funding is challenged, right? We're limited with our resources, and so we ask our space to do so much. You can't just do one thing. We don't have that luxury. You need to do 2, 3 things, and to really make the space the best and flexible and kind of future think. How are we adapting technology to inform, hey, someday I know my patient population is going to be comfortable and they're going to want to do all, remote check-in process where all I have to do where, I'm waiting where I want to wait and I'm going to be able to self-room. I'm here. Why can't I just go into a room? My room's ready. It's using those technologies and laying out the clinic space or the healthcare system to allow for that design evolution and design innovation. Yeah.
I love this because I've heard both from you, Angela, and also from Erin, consistent themes, a focus on wellness, a focus on prevention, flexible, adaptable environments, a focus on safety, security, resiliency, and amidst of the cost pressures within the sector, a focus on how do we innovate the spaces that we have. I'm going to quick pivot back to Erin for just a minute. And, we're talking about a lot of spaces to serve a healthcare ecosystem, to serve care delivery in an outpatient setting. Erin, kind of bouncing to you, how is this shifting the strategy for the inpatient setting?
Well, you're asking me like I know the answer to that, huh? So I think I might. Well, first of all, let's talk about outpatient real quick, because honestly, as we look to wellness in the community, can we please talk about that? Can we please make our health communities healthier? We are shifting to programs and projects that actually are community based now. In fact, Chantily well knows this. We are working with Mortensen on the West Coast in Hillsboro, Oregon, developed the first kind of community health based center that is adjacent to the senior center, and it's across the street from the Safeway. And Providence will be offering many services within that building, which also will have wellness. So finally, Providence, this big old Catholic health system, is finally on board with these concepts that were developed, a billion years ago. So yay us. But what does that do to our inpatient settings? Well, guess what? We're shifting that healthcare out to the community where it should be. So you're going to see acute care facilities handling a whole lot sicker population. And there's a lot of talk. There's a lot of talk right now within our own healthcare system about, okay, well, who's the doctor who's going to go out to the clinic, and who's the doctor who's staying at the hospital in case somebody has a heart attack? You wouldn't sure that this audience would absolutely believe the kind of conversations that happen out of that. And you just are so glad you're on a call and not in the room when those conversations are happening, because doctors, I love them. They are the ones who provide our care, but they've got their interests as well, and they want to be at the best place for their patients. So there's a lot of conversation from the caregiver side, the provider side, about how that medicine displays across our regions and within our regions, within those community spaces. But one thing I do want to pivot back, because this is a real estate audience. This is one thing that we've learned. You've heard about supply. Many of our suppliers actually have their own distribution centers. Well, if COVID taught us anything, is that we cannot rely on overseas companies to provide us our PP&E. I mean, wow. Talk about the scales falling off your eyes on that one. So one of the things we're talking about at Providence, and I sit on our emergency management system calls, is looking at facilities within our regions that will hold our supplies and be near our regional centers to be able to distribute PP&E for the next pandemic, which, by the way, there's 2 new cases of Ebola that just broke out in Africa, but not to put it down around this conversation. So more shift off the inpatient campus out into the community, and with a balance of how that looks going forward is really, that's the magical trick we're all trying to figure out here at Providence. So thanks, Chantily, for the question. By the way, fun fact, guess how many, I'm going to put this for your question in the sidebar. Guess how many pairs of gloves Providence orders in 1 month during the height of the pandemic? Just go ahead, put it out there. And I'm just curious to see if anybody has any idea what we did. So I'll stop there.
Chantily, you back? I think you're on mute.
Well, that was a fascinating technical glitch. I love it. I'm sure, Erin, you covered kind of this shift from happening in the inpatient setting. Chatting more about really moving care away from that environment. And hopefully somebody was able to kind of carry on the conversation outside of that. For time, let's do a quick shift. I want to shift from the care delivery setting now over to kind of the bio and life sciences sector. And again, just to set a little bit of context for our audience. So, there was a report issued by JLL, which is a global real estate firm not long ago, that noted that R&D spending is expected to grow by $213 billion by 2014. And investors are certainly taking notice of this, with real estate investors focusing more on the bio and life sciences sector as a result of the role research, development, and manufacturing is playing during this pandemic. And this appetite was further signaled at the end of 2020 when Blackstone, the commercial real estate and private equity group, announced a $2.5 billion deal for a group of life sciences buildings in Cambridge. So let's talk about these assets, because there are unique attributes that play a role in creating that dynamic environment for innovation to occur within life sciences. And this includes attracting top talent within communities. It includes ensuring that there are amenities to support desired lifestyles, adjacencies to research institutions and medical centers to allow for translational medicine, a sustaining commercial environment to enable the commercialization of treatments, therapies, and technology, as well as supporting capital and policies to enable that life science cluster to succeed. And so in Minnesota, the Destination Medical Center began as a unique public-private partnership with a $5.6 billion plan to advance this local ecosystem around the Mayo Clinic and leverage Minnesota's MedTech Foundation in order to create a global destination for health and wellness. And now centered in Rochester, which is the home to the Mayo Clinic, the DMC initiative is spurring and delivering the infrastructure needed to support this ecosystem, including the development of a sub-district called Discovery Square, which is being built in collaboration with the Mayo Clinic and adjacent to this campus. So now here to discuss this unique environment of bio and life sciences is Hilary Blair, and she brings an important user perspective surrounding the development and design of these critical facilities. And so Hilary, maybe walk us first through your role with the Mayo Clinic, and then share with us, what are some of these unique attributes of bio and life sciences?
Sure. Well, thank you again for having me. My role right now at Mayo Clinic is as a research administrator. I have several different departments that I support. So molecular medicine is one of them, but I have several basic science departments, as well as space. I am currently the secretary for the Research Space and Equipment Subcommittee. I partner with our chair, Dr. Dan Chumperlin, to help planning around campus for our research labs and various research spaces. And we look at an overall strategy on how we locate different laboratories. One of the things that I will say, so Mayo Clinic we are a 3-shield organization. So we have research, education, and the practice, and we integrate all 3 of those in everything that we do. So as I talk about the labs that we build and support, we have students in those laboratories from the graduate school. We have students from the medical school that are right there next to the scientists at the bench doing work. We also, the integration with the practice, we have physician scientists that have their own laboratories, as well as collaborations with physicians and scientists to come up with those different discoveries. We have what we call our DTA, Discovery Translation Application Continuum. And so our life science laboratories are critical in coming up with those discoveries to then go into the translation phase to eventually apply at the bedside. And an example during COVID would be last spring when there were shortages in transport media for testing. Our clinical department of laboratory medicine reached out to our scientists in molecular medicine to say, hey, help us. How can we transport the samples? And so the 2 groups partnered together to come up with a solution that they carried forward on that clinical side. So it just shows that real integration of our scientists and our physicians. One of the things that I would say right now is that we are very short on space. And we have traditionally we recruit a scientist or a physician scientist, and here's your 4-wall lab, remodel it with what you need to support your program. That's led to this shortage. And so in the last several years, we have flipped to what we're calling condominium models. And those condominium models, we have several scientists, we have different clinicians working out of that same space. And so we're opening up those spaces more. Now, fast forward to as I mentioned, we're building the Anna Maria and Stephen Kellen research building. That is going to be the principal for the entire building. And as we are working on that, the themes around that are centralized on team science. And so we're creating teams to go throughout the building. Now, how does this tie to Discovery Square at DMC? The building is in the heart of Discovery Square, or the Discovery District. And we have had regular meetings with the team to stay on top of what's going in our building, how that can create synergies with the different companies that are going to be going into Discovery Square 1 and the future projects that are coming. So we've stayed in touch with the communications. In terms of timelines, we started in a visioning phase in December of 2019 for the building. And as soon as we got done with that visioning phase is when COVID hit. And so we had to put the building on pause. When we came back around June-ish to start working again, there was a lot of questions around how are we going to design these labs and these buildings moving forward, knowing what this environment is, because a lot of people were uncomfortable. The thing that we have to remember is that the research in many cases is critical and can't stop. You can't do it from home. So we're always going to need physical laboratory spaces to conduct a lot of this research. There are shifts in how we're looking at doing the work, but to answer the questions that a lot of our staff have around that is, and we just talked about this last week, talking about air handling and changing how we do that. I know flexibility has been mentioned a lot, and one of the main priorities for us in this is going to be flexibility. our floor plans are being established so that we have what we're calling wet, damp, dry space. So the wet is going to be your typical tissue culture. Damp is an average lab bench, and dry is your desk space. And the flexibility that we want to create, we want to bring in scientists and clinician investigators that can just plug into the space as is. And so those wet spaces, those rooms, we're going to be able to flip between tissue culture, between microscopy, between procedure rooms, so that we don't have to continually remodel spaces to accommodate the different people that we're bringing in. Because as science shifts, our focus shifts. And obviously we've all had to pivot when it came to research around COVID. And so how can we make these spaces adaptable as the direction of the science changes? That's really our main focus. And so that's just kind of a sneak peek on how we're handling the new buildings going forward. I don't know if there's any questions.
No, just maybe a follow-up question, Hilary. You know, I love, you know, there's this adaptability, there's innovation. In terms of being able to kind of shift quickly certain uses within an existing lab, what potential impediments might there be, or what to expect to be able to quickly shift from one use to another?
Honestly, it's culture change would be the number one thing I would say, because we are working with scientists who aren't used to working in that kind of environment. And so creating a welcoming environment to make sure that they're comfortable with the fact that they are going to have their needs met to continue their programs. Engineering wise, making sure we have the proper, airlines, and different features in those rooms to make it so that we can just pull out a tissue culture hood and move in microscopy or mass specs or things like that. So the approach that we've taken, we are not working from we have a list of people and you're all going in. We're not going to customize. What we've been doing is working with more panels. And we've done general broad surveys. I sent out a survey to 1,200 researchers and basically said, tell us about your day. What does your dream lab look like? How much time do you spend in certain areas of the laboratory? And so we're developing different phenotypes of the kinds of research that are going to happen in the building. Right now, we just started doing kind of the stacking diagram work, and we sent out, we had 2 sessions with about 70 different investigators to really lay out, here's what we're thinking, here's what the floor plans are looking like. Now tell us, get down to the nitty gritty, how many freezers, how many this, and we're taking that generic information from everybody and kind of plugging and playing to see what is it going to take to make things flexible based on those. Another part of the flexibility that we're looking at is the expansion and contraction of individual programs, because that's always a constraining factor as well. We have a scientist who gets a new grant, they need to hire 5 more people. We have another program that maybe they had 2 grants, now they have 1 and they have less people. So how can that space accommodate those types of teams working together? One of the things that's going to be critical is a management strategy around the space and having focal points that are focal people who are responsible for managing who has what bench and who goes where.
In describing these environments, a lot, flexibility. How much does modularity, play a role into these environments? Are there specific kind of design approaches that you're pursuing?
We're talking modular benches. So we would be able to just move them in and out. If we have a big piece of equipment that needs to come in, we would just take the bench out. So that's going to be key.
All right. And then in terms of some of the partners that you're working with, our audience is comprised of a broad array of real estate design, construction, and other stakeholders, other peers in your industry. What advice would you give them as it relates to this process, the development and design of this process?
I would say the biggest thing for us is understanding the culture of the group that you're working with. And what we looked for people who had experience building laboratories, but we also wanted them in these visioning sessions to understand the culture of Mayo, because it can be very different for some things. And they've been fantastic about working with us, talking with us, understanding that. So I would say some active listening and exchanges with the groups that you're working with.
Wonderful, wonderful advice. And last, I want to make sure that I catch questions as they're coming in. It looks like we have a question from Chris Shad. What is the annual research budget at the Mayo Clinic?
The last time I checked, it was in the neighborhood of, I believe, $680 million.
Significant investment. Wonderful. Wonderful. Thank you, Hilary. I'm going to pause here because this is a great topic of conversation. We have an expert who's able to, talk with us around, some of, the user perspective. Pausing for a moment just to poll the audience for any other questions. Otherwise, I'm going to be pivoting over to the development and community side of this conversation. And Connor, who is with us from Ryan, based on what you've been hearing in terms of the conversation on the care delivery side, in terms of bio and life sciences, how are you, or how is the development community reacting and responding?
Yeah, I mean, pardon me. I think we have to understand that the shift, specifically in healthcare from inpatient to outpatient, obviously took place prior to this pandemic. Oddly, I think the pandemic has done two things. I think it shed a light on the need for outpatient facilities, but at the same time, it's been balanced by a lack of capital due to these hospitals being hit, or health systems being hit, or health providers being hit by the pandemic. So you have this balancing act of realizing that we need to have this care in the outpatient space, but we've also taken a massive capital hit through this pandemic, through this last year. I mean, if you look at the hot topics right now in healthcare, you look at the projects that are really kicking off. I made a quick list of them, and all of them are pushing more and more services outside the hospital. A big one that we're looking to do quite a few right now is consolidated service centers. So we're moving laboratory medicine, billing, printing, marketing, sterilization off campus, off those expensive campuses, and into a place where we can consolidate them and help them reduce cost. The other thing that we're looking at is you look at behavioral health. There's a major behavioral health issue right now, and we just don't have the services in the United States. We're taking those services off the hospital campuses and building unique facilities that will cater to them. Rehab hospitals, same thing. Again, taking it off the very expensive campus, putting it in a outpatient market with accessibility and traffic counts that help provide good recovery times. Surgery centers, I think we've seen that trend that started well before this pandemic. I think we're going to continue to see it as the insurance companies, I'd say, accept it or even encourage it in reimbursements. And I think, pardon me now, I think it was Erin, we're doing a massive overhaul for health pavilions, health plexes, whatever you want to call it, that's changing the face of the hospital. It's essentially, unfortunately, I think the mass public thinks of the hospital as a place where you go to get sick. Maybe they don't think about having birth, but they think about getting sick. You go to the hospital. And these new health pavilions, these new health plexes are basically a new front door for the hospital to basically say, listen, we want you to obviously get better, but we'd rather you stay healthy. And I think that's a really encouraging aspect of where we're going in healthcare. Urgent cares, freestanding EDs, and of course, the traditional medical office building. But all these are open. And I think what is really interesting, and I'm glad Angela brought it up, because I've been tooting this horn for about 5 years now, or maybe 7 years since I started with Ryan Companies, is I think there's a way to redo space, redesign space, and actually help with FTEs. And Angela, brought this up, was looking at the waiting room area. I know this seems like a very small thing, but when you look in a large medical office building, you have 15 waiting rooms, you have 15 people at desks managing the people coming in. You're having people sitting in a lobby. I hope, I don't know, but I hope that this pandemic helps us rethink the virtual waiting room. I think with all the technology that we have, almost every person I know has some sort of mobile device that will allow them to check in with their doctor. There's really no need that I can see anyway, for us to sit in a waiting room for 30 minutes to get into an appointment, when we can really take some of the lean principles that our hospitals are using right now in providing better patient care to provide a better way for the patient to experience healthcare. So I think, in summary, I think a lot of it's changing, but I think the path that we were taking was a good one. I mean, I'm thankful that we moved, I'd say in the last decade, to this outpatient model of care, because I think it's set up a pretty good map, if you will, of how to handle the pandemic. I think we will be reimagining spaces. We're doing spaces right now in medical office buildings that are larger waiting areas that can be repurposed if necessary. We're looking at spaces and how they interact within that office with perhaps reduced loads of FTEs in that office to create more space. And then also trying to understand how a medical office, surgery center, et cetera, can provide those things that are critical when a patient has to be there, but also allow for workers to work from home, but still be assimilated within that process within the brick and mortar.
Connor, I think you're touching and absolutely hitting on what I like to call kind of an optimization of real estate. Real estate truly is a function of care delivery, and how can we optimize that so that it enhances and enables quality patient care. I want to quick touch on a question that's come through, and whether you'd like to touch on this or Erin, Angela, or others. The question is, how will healthcare systems handle the hospital vacant square footage? And as services are moving out of the hospital setting into an ambulatory setting, it's certainly creating vacant space. And it's the question is, how is that backfilled, utilized? You kind of touched on it a little bit, Connor, and Erin, certainly I'd love you to jump in as well.
Oh, well, if you ask any hospital system, they'll tell you there is no such thing as vacant space. They've already spoken for it even before the department left. But in this, so what's going to happen when somebody actually admits that we didn't actually have a plan for that vacant space is as more care services will be provided within the hospital environment. As Connor mentioned, it's wise to get anything that's not eye occupancy relevant in a hospital off the campus. Get it out of there. You know how much we pay for that space? It's ridiculous. So let's focus on care, the most intense care we can at these hospitals, and fill those vacant spaces with, I don't know, patient care. And oh, by the way, Connor, we hope people don't come to the hospitals to get sick. We kind of hope that they come to the hospitals as they are sick. Just can we please? I just have to put the plug. We have some very good doctors, but we really don't want to see you try to get sick at our hospitals. But I hope that answered the question. I
think to your point, hospitals aren't going anywhere. I mean, we talk a lot about, the trend, right, of moving into that outpatient space, but the inpatient space in those hospitals are not going anywhere. Hospitals are still being built. They're probably being re-envisioned, but I've never met a hospital or a health system that says we have too much space in our hospital.
No. You have people like me telling them they've got too much space, and executives don't want to hear that. I swear to God, when they go to their executive schools, they are taught, get as much space as you can and be sure to get a tower built for you in your name before you leave.
In your name.
Yeah. This is Angela. The one little thing that I want to add on as well is hospitals are going to the acute care that's being provided. There are more complex cases. And so the spaces are evolving as technology evolves with robotics and AI and all of that. We can't also forget about patient experience and also staff experience. Staff has been tremendously stressed with the current last year. And then knowing the shift to creating very acute care, they're stressed because the complexity of cases is all the time every day. They don't have an easy patient anymore because those easy patients have been moved out to the outpatient care. So respite spaces for those staff members are going to be critical.
Well, and as Connor mentioned, the ASC, ambulatory surgery centers, are seeing much more complex cases due to licensing. So nobody ever thought you'd ever do a total hip replacement in ASC. Oh, sure, we're doing that there now. And even cardiac cath. I just had this conversation the other day. My cardiac cath, are you kidding me? Yeah, no, we can do that in an outpatient setting now. So who knew?
Yeah.
Who knows? You can probably replace your own heart valve in 10 years using, one of these. I'm guaranteeing it. Right
It's
there.
coming. It's coming. And
To that
to
point, Erin, to that point, I was going to say the last 5 ASCs that I've developed and built have all had overnight rooms, 24-hour. And it's
Yes, and that licensing is very specific to Connor. So not to get into the licensing
Mhm.
conversation, but
Yeah.
you have to have a state that allows you. Oregon just barely squeaked a 10-bed, 24 hours, 23.99 hours a day. Yeah, sorry.
Well, I want to be cognizant of time, and as part of this conversation, our communities and our cities play certainly an integral role in creating these healthy environments, in enabling the work that the Mayo Clinic does, that Hilary does, and her teams, as well as creating the healthy environments that we see from Providence and others. Bruce, I'm going to pass the baton to you. I'm going to quick pull up some materials
Sure.
first.
Thank you. Yeah. And an introduction why she does that, like hospitals are not going anywhere, cities are forever. And so that gives us a foundation for most everything we do. What you have before you is a map, and there's a 40-year land use and development science that recognizes regional airports by the term airport city. It's not the center city, it's not the suburbs, but it's the collective 360 degrees that functionally surround and serve the airport and provide a location like MSP in the Twin Cities and offer the strengths for economic opportunity, an airport focused economic development and a global access and reach. Apple Valley offers a piece of that, having 400 acres where sand and gravel mining for runways, highways, and buildings has become a location for significant development just miles from MSP. Next slide, please. The following aerial shows all 400 acres. Phase 1 utilities and ponding in 2020 for a 40-acre retail development, and true expansion to the 2021 opportunity phase now underway for health services, medical device development, manufacturing, and health and wellness business strength, and just-in-time proximity to MSP. I won't take any more time to say that one again, but it's a mouthful. Next slide, please. So the point here is developing 400 acres under control of one owner recognizes both ease of entry and the significance of what is being discussed. It's a significant undertaking and a very large development location to be upgraded here with an overlay of downtown Minneapolis, just so people understand conceptually what we're talking about. Next slide. There's a master plan for approximately 3.4 million square feet of possibilities, 3,000 to 5,000 employees, and whatever the future framework is going to be. And the best contact is mentioned there, Russ McGinty at North Central Commercial. Next slide, please. I believe he's attending the program today, so you might be able to connect with him online. It might be unheard of in the Twin Cities, but first phase supportive commercial is secured and moving toward construction this year by HJ Development, a well-known and experienced retail owner and developer. Alon's Byerly's is seen in our future, and it goes back to the point that's been discussed multiple times today, strong support for that retail presence in support of healthcare and medical services nearby. We already have 930 acres in Apple Valley devoted to retail and services, and this 400 and the business aspects of it are going to move forward. Next slide. Oh, but there's more to this story. This is probably the only time they hear me say it's not about Apple Valley. The strategic value proposition is to develop MSP as a global wellness hub connected to Wallonia, Liège, Belgium, as the largest European distribution hub, and leverage the available land for development and manufacturing to match our regional strengths in food, health, and wellness leadership. And this represents a nonprofit global wellness consortium that has been formed recognizing these elements and all the multiple partners, public, private, academic, that are connected to this effort in the region. Next slide, please. This slide is a little complicated, but when you have multiple partners, multiple interests, and they've all come together under this umbrella of global wellness consortia, that it's a large following. It includes Mayo. Mayo and destination medical staff have been at the table. Medical Alley, people are familiar with, Greater MSP, DEED, and the multiple representations from cities, healthcare, food and nutrition, and just-in-time logistics systems and security are all part of this, and it's all focused at the center and radiating from the airport. One more slide. Oh, it does have something to do with Apple Valley. There is an Apple Valley marketplace, and it leverages all the strengths I'm talking about, being part of an airport city for the global future of Minnesota. And what are the pieces to that? World Expo 2027 being worked on by Mark Ritchie. The importance of the global consortia. And we mentioned Hyperloop. That technology readily available is coming to the Twin Cities, coming to Mayo. And if you want to talk about just in time, spend a few seconds going from here to there on that type of mobility device. And finally, Apple Valley is the center to the Minnesota Zoo. There's 500 acres at the zoo, and under the leadership of John Frawley, nature and wellness is the center of the discussion and how they can partner, particularly with the World Expo 2027 that's envisioned. I'll close just by shout out. There may be many of you in the room that are a friend of Bill Goines, retired Fed ex-executive. And he's the local leader that drives the Global Wellness Consortium effort. And Michael Wright was the one that created that complicated slide that I have to pay $30,000 for. And Mayor James Hovland, who should be recognized in the Twin Cities as a leader in many things, is the chair of the Global Wellness Consortium. So it's not something that's kind of made up on the back of an envelope. It's a partnership of multiple disciplines trying to move this airport, this state forward. So that's my story.
Well, thank you, Bruce, for talking to us about how communities play a role in this broader healthcare ecosystem. This has been a dynamic panel today. We have covered a lot of ground. And I think as we think forward, as we reimagine what does healthcare look like, what does research and development look like, what we're talking about really is healthcare as an ecosystem of care. I want to thank our panelists for sharing their expertise and their time. I want to thank the audience for your patience with me dropping out for a quick technical issue break. And I'm going to turn the baton now over to the Real Estate Journal as we shift into our next section.
Well, if I get the baton, I'm not a very fast runner. So that's an unfortunate analogy for you all, because if I'm the last leg, we're losing this race. Okay, just back to my screen share here. Thanks, everybody. Fantastic panel, great information. I really like these national events, and all the different perspectives are wonderful. I hope everybody got a lot out of it. If you're on the next panel, now's the time you want to activate your camera and activate your microphone. If you're on the last panel, feel free to say thank yous and goodbyes. I'm going to show real quick here. This is the next panel coming up. Don't forget about these LinkedIn buttons, because this, you said, hey, I can't network on a virtual event. Sure you can. This is the one way. Go in here, punch that button, see them on LinkedIn, connect with them if you don't know them already. Okay. Let's see, multiple screen share here. This is our next panel right here, medical properties and life sciences investment opportunities. And I promised I would do one quick one of these before we move on. So this one's a trivia question. You ready? What side of a duck has the most feathers? The outside. There you go. There you go, folks. Tell that one to your kids. Okay, I'm going to turn it over here. Trent, this is your panel. If you need anything, holler at me. Hey, Todd, I'll be here in the background waiting, watching. Have a great panel. I'll be back in an hour to help you all close up.
All right, I think we have everybody, so welcome everyone. This is the Medical Properties and Life Science Investment Opportunities panel. I'm Trent Taylor. I'm with Healthcare Trust and Company, which is a public non-traded REIT that focuses on medical office properties and senior housing assets, as well as operating senior housing asset properties. Why don't we go ahead around the room and introduce ourselves? Chris, if you want to start.
Well, good morning, everybody. I'm Chris Shatton. I'm with the DMC Economic Development Agency. I'm the Director of Business Development for the agency in Rochester, Minnesota.
Caitlin, you want to go?
Sure. I'm Caitlin Drod, Vice President at Capital One on the Medical Office Originations team. We're the largest lender in the medical office space. We also lend on life science assets, which I know we'll get into a little bit later.
Joe?
Morning, everybody. Joe Magliochetti. I'm the Chief Investment Officer at Remedy Medical Properties. We're a private investor, owner and manager of medical office buildings across the country, based in Chicago, but about 20 offices nationwide.
And last but certainly not least, the best hair of the group, Brent.
Good morning, everybody. My name is Brent Webb with Mortenson Development. I think some people are familiar with Mortenson. We're also a construction company with over $6 billion in revenue, but we have multiple different business lines from solar, wind. I work for their development group, and I'm also helping facilitate some of our strategies for life sciences nationally. Good to see everybody. Happy Wednesday.
Great. Well, that's our panel for today. You know, I guess we have two kind of segments to talk about, more on the medical office side and then life science. So I guess I'll start with Joe to kind of give us the state of play, if you will, kind of what you're seeing transactionally, cap rates and markets.
Sure. Well, over the past few years, medical office buildings have become kind of an increasingly favorite target of institutional capital. There's always been, 10 years, 20 years, a lot of activity driven by public REITs that have invested in the space. But especially over the last 10 years, there's been a growing influx of private capital into the sector via private equity funds and those types of investors. We're one of those participants. We're a manager and investor of a series of private equity funds, and we've been really active over the past 10 years or so. Bought our first building about 11 years ago, and today we have almost 600 buildings across the country. So we're kind of a poster child for the increase in private capital coming into the sector. And I'd say in like 2018, 2019, the pace of that started to increase. And we saw increasing demand from our own investors to kind of upsize their commitment to the sector. That's due really to some of the fundamental characteristics of medical office buildings, and maybe a lot of our participants have heard this story. But the idea is that investors are looking for predictable cash flow, and in medical office buildings, you've got a great combination of fantastic demographic tailwinds with an aging population and a growing healthcare industry and an increasing use of healthcare services across the country. You've got a really high retention rate among your tenants, much higher than a traditional office building. And our portfolio is about 93% retention when it comes to renewals of your tenants, which far outpaces a regular office building. You've got a really low default rate and some really interesting credit profiles across the business with health systems and large physician groups in particular. The challenge for institutional investors has been that the deal sizes are smaller. And so you really have to, in order to have a meaningful execution of your allocation into medical office, you really have to commit to acquiring smaller transactions often and accumulating a portfolio with what institutional investors might view as a smaller deal. A medical office building is usually 50,000 square feet, $18–20 million per deal. So in order to find what an institution would think is meaningful, you've got to accumulate a lot of buildings. But those underlying fundamental characteristics of the investment of the asset class have continued to attract capital. And I think today we're looking at kind of the highest level of interest and activity that we've seen to date. There's a bunch of new capital coming into the sector from both domestic and foreign participants. A lot of big institutional investors have kind of accelerated the pace of their allocation of capital. And that's really the factor that contributes most to pricing. The appetite, the demand coming from capital is what influences cap rates the most in our experience. 2020 was an interesting test period where medical office buildings may have been seen or theorized as kind of acyclical or countercyclical and not exposed to as much as other real estate classes to the ups and downs of the general economy. And in 2020, obviously, we had a significant challenge on our hands in society with the pandemic, and medical office buildings probably even outperformed what they were expected to do. The stability of rent collections, the stability of occupancy. In fact, probably the positive absorption occurred, I would guess, across the country in medical office buildings in 2020, which is, completely different from most other real estate sectors. So that performance, I think, kind of intensified even the flow of capital. So there was a little bit of a hiccup mid-year. The capital markets were a little skittish about investment in general, and medical office wasn't immune to that at the kind of the debt markets and equity markets. But toward the end of the year and certainly into 2021, we've seen the pace of investment accelerate. Cap rates are compressing, especially for higher quality trophy type buildings, and even more so for portfolio investments, which are attractive to these institutions because they can achieve scale faster and meet their goal of an increased allocation into the space. So really busy, competitive space. I'm sure Caitlin and the rest of the participants are seeing the same thing.
Yeah, I mean, we've had very strong rent collection, right, which is really the fundamental behind all of real estate, right? And so we certainly have seen a cap rate compression, and certainly the volume of deals kind of shrinking. Caitlin, what, as far as on the debt side of MOB placement, how has underwriting changed from pre-COVID days?
Yeah, I think that at the beginning of all of this, we were trying to assess, while there was so much market uncertainty, what was going to happen. We were underwriting, what we thought, doing some sort of COVID analysis based on what we thought may happen. We now have, unfortunately, we're a year into this, and we now have 9 months of real data, which, to echo what you just said is, and what Joe has said is, we've seen rent collections across our portfolio in, at least the 95% range. Where there were requests for rent relief, it was usually in the form of rent deferrals versus rent abatements. So it's rent that is going to be collected over time. And I think that we've just seen again, to everyone's point here, that medical office is a very resilient asset class, which is what we thought that it was. And it's kind of proved that strategy out. So, I think for us, we've seen that this is a space that we want to continue to be in. We've seen that we have real data to go off of, that there wasn't a huge impact across our portfolio. And I think now, before we were a little bit more conservative in our underwriting, and there were different things that we were taking into consideration. But again, now that we have real data and we've seen what has actually played out over the last 9 to 12 months, we're not doing anything largely different than we were before.
And Chris or Brent, do you want to kind of take a similar approach on the life science side?
Sure, maybe.
Chris, you want to go first?
Yeah, why don't I go first, just to give everybody some context for what's happening down in Rochester. And I'm going to share my screen here, if you don't mind. I've just got a handful of slides to go through to give everybody a little bit of context. DMC, Destination Medical Center, is some legislation that was passed in Minnesota in 2013. Master plan was approved in 2015, and it's really a state investment in the city of Rochester. See if I can get slides to advance here. And it's a 20-year initiative. Mayo Clinic committed to $3.5 billion of capital investment in its operations in Rochester. Our economic development agency, the DMC EDA, stood up in response to the legislation. It's tasked with attracting another $2.1 billion. And the state said, that's great. Well, we'll contribute $1 for every 10 between city, county, and state revenue sources of $585 million. And it's a prove it model. It's on the back end. So every year we have to report what development has taken place over the year just ended. And then state funds come back to us based on what has accumulated through that year. And the whole idea is to transform Rochester into a global destination for health and wellness. We have 2 to 3 million visitors every year that come to Rochester. We're a community of about 125,000 people, but we want to make sure that we continue to hold that position as a place for people to come to. So our mission is really to improve that patient and visitor experience, to increase downtown housing options, to diversify our economy, and really invest in the infrastructure to support the growth that we know that we are going to see. The state funds, the state, city, and county funds that come to us out of that 585, they are expressly to be used for infrastructure support, not for Mayo Clinic, but for the development of the infrastructure and to really attack these 4 bullet items here. This is the sandbox that we have to work in. It's about 1 square mile. This is the DMC district. On the right, it's the core downtown district of Rochester. And on the left, that's the St. Mary's Hospital campus, about 1 mile away. So overall, we have about 1 square mile to work with. The development dollars that we count year by year have to take place within the boundaries of that district. Mayo's capital investment is the entire city, but the ones that we attract in have to be within the boundaries of that. And then the 585 that we have available to us, or will have available to us, knock on wood, over 20 years, have to be spent within the boundaries of that DMC district. This is what has happened so far through 2019. 2020 figures are not audited yet, but we're working on those figures. Cumulatively, we're at on that march to 5.6 billion of investment. We hit 963 million. So a really good start after the first few years, with another 15 to go. A combination of Mayo Clinic investment, which has been pretty steady, and then the private investment that we attract in from other developers, which has steadily gotten larger year by year. The last 2 years has been right around $134 million within that 1 square mile district. Specifically around Discovery Square, which is the work that we're going to talk about here. It's a subset of the 1 square mile. It's a live, work, play innovation district, where we're really working on bringing in Mayo Clinic partner companies to establish a footprint in Rochester rather than working from a distance. And but also there's residential units going up. There's a linear park that's going to be developed here shortly through the heart of this, the Discovery Square district. So boundary wise, if the green outline is the DMC district, Discovery Square is a subset of that district. And just a real quick snapshot of what has happened. If this was the boundaries, and this is what things looked like in 2015, you'll see a lot of surface parking lots, the blue buildings representing Mayo Clinic buildings, and a little bit of residential in the bottom there, a little bit of business space. This is what it will look like by the end of 2021, maybe 2022. So a significant amount of development has taken place and will be taking place. A combination of residential units, street enhancements, business buildings going up, which Brent is going to be talking about, more Mayo Clinic buildings, and then Discovery Walk running north-south there through the middle of all of it. More importantly, I would say, maybe this audience might think differently, but for us, more importantly, is the ecosystem and the organizations and the people. This was 2015, and this is what it looks like today. So as we convert those surface parking lots to functional space, businesses, universities, retailers, restaurateurs are moving into that space. So, so in the context of what I'm going to be talking about, that's the backdrop and the background of what we're doing here in Rochester. And I think Brent maybe has some more detailed information to share.
Yeah, Trent, if you're okay, I can probably just keep going.
Perfect.
Let me share my screen here. I thought Chris was actually going to share my presentation. So I think, you know, kind of going off of what Chris stated, a lot of our experience, and I'd say it's consistent with the trends that we're seeing across the country with Mortensen, are consistent with what's happening within Rochester. Let me see if I can move to the next slide here. I kind of quick touch on this, but I thought this was important to kind of show the footprint that Mortensen has, because we really do have a national perspective when we think about trends and specifically what's happening within Rochester. But quickly touching on Discovery Square, Chris already mentioned the details of the specific district, so I'm going to point to the specific building that we're talking about, which is 1 Discovery Square and 2 Discovery Square. And for some context, we've actually been partnered with the EDA and the city of Rochester since 2016, as well as Mayo Clinic. And we really kind of embarked on this journey as one of the first people to help to actually benefit from the DMC funds that were established. And we were kind of in a little bit of a unique pioneering position because it really was a sea of parking lots. And instead of having that close proximity to maybe the Guggenheim or other facilities, side note, there are about 2 million square feet of lab facilities within close proximity of 1 and 2 Discovery Square. We decided to remove ourselves a little bit, which I think is a pretty bold move. If you've ever been to Rochester, everything's connected by subway. And what we were really trying to do is create a new center of gravity. I think a great representation of that, we were on these initial visioning sessions with Mayo Clinic and Chris and others. And we were talking about these different researchers that might have space within 1 Discovery Square. And one of the researchers said that if we have people wearing ties in this building, it would be a failure, which I think is a pretty big representation of how Mayo was actually shifting, but also the culture that they were hoping to create within this new facility. So I think one thing that was unique, and I think this is pretty consistent with other innovation districts that are successful across the country, is, you know, starting with that reason why. Why should companies move not only to the state of Minnesota, but why should they move to Rochester? And these are the 3 critical things that we kind of took away from our research, but we have also implemented within 1 Discovery Square, as well as what we're contemplating within the second phase and future phases. But obviously, Mayo Clinic, #1 health system in the world, their influence, but also the relationships that they're creating. I'm sure you saw the last slide, and there was an article this week that, you know, Google is having their first location in Rochester, not the Twin Cities. It's that access to Mayo. That is a really critical piece to what has made the project successful. That other piece too is that culture. You've probably heard this, which is consistent with a lot of innovation districts. There has to be more than just the building. There really has to be that connection point to have these spontaneous collisions that will eventually, hopefully, translate medicine and create new technologies. And that really gets to the third one, which is because of the people that are intentionally in this building, because of the collaboration that's happening through intentional programs, the idea is that it's going to shorten that continuum of new technologies from bench to bedside to ensure that these actually are new technologies that are within the healthcare system. So real quick, and you've already seen some of these companies, but the first building, One Discovery Square, was 90,000 square feet. I think that the easiest way to summarize this building, it was really taking the approach of a Swiss Army knife, where we were trying to accomplish a lot because we were really the first building here. So it was a little bit less efficient. We had more common space, but we've always contemplated the first building, the second, and future phases to be more of a campus. So it'd be shared amenities, shared access, shared collaboration. But I think what's transpired over the past, I'd say, few months is that there really has been a lot of interest within this building, which is the reason why we started the second phase. And the phase 2 building is about 120,000 square feet. I'd say the biggest, I guess, lesson learned from the first phase is that there really has been that need, and we're actually still contemplating there's going to be a need for more type of amenity spaces, specifically larger conference rooms, larger training centers. This will be one of the first wired square buildings in Rochester, which is essentially we're investing more into the technology infrastructure so we can take advantage of the future 5G. But also this building, as well as the first building, does have high intensity CGMP lab space, which you're not seeing a lot of being done within Rochester. So we're really kind of positioning it being that place where all lab can be within Rochester. That's where I'll end for right now. So I'm sure there'll be questions and more discussion.
So Caitlin, maybe you can talk about what you see as far as life science on the debt side, similar to what you had given us on the MOB.
Yeah, absolutely. Overall, we've seen an increased interest in the space. This is, a space that we've been in for quite some time, but over the last, I would say, 5 years, there's been a significant increase. Again, from similar to MOB, a lot of institutional investors. We typically on the debt side see people wanting lower leverage, longer holds, and then the more institutional people coming in. A lot of the reason why is, to Joe's point earlier, these life science assets tend to be much larger transactions. A single asset can be in the hundreds of millions of dollars. And so it fits a little bit more with the strategy that they're going for. It's not the, buy a lot of small assets. It's, a one large transaction on a single building. In the space, again, I mean, the supply demand dynamic in this space just continues to be very unique, especially in the 4 core geographies, is what we call them, would be Boston, San Francisco, San Diego, and Raleigh, Durham. But we've seen recently people expanding into and more interest in different markets, Philly, Chicago, expanding out of, specifically Cambridge and Boston into more of the suburbs of Boston. So we're starting to see that happen, kind of moving out of those 4 main areas, but we're also seeing a lot more conversion transactions where, because of that supply demand dynamic, where, in Boston, Cambridge, there's oftentimes negative vacancy where people are signing leases up in the future. The rents are incredibly high, much higher than traditional medical office. And the demand is still there. So we're starting to see more conversion. For us on the debt side, it's definitely, we're evaluating these on a case-by-case basis. It has to be the right market with the right, the right sponsor, the right asset, because a lot of these, because of the way that life science needs to be built out, not every traditional office building can be converted. So, you need higher ceiling heights because of the ventilation systems that need to be in these buildings. You need the floor load is higher. So again, we're evaluating them case by case, but we're starting to see more and more and more of this, especially in the big markets where there's still a very, very high demand for this space. And then obviously, this year, I think the pandemic has put a focus on life science even more so than there already was. Not that, the development of a vaccine is the only factor here, but I think that it put life science on the map for people who hadn't previously looked at it. And the demand for lab space is obviously still very high and increasing even more so because of the current state that we're in.
So do you see, I know Joe had mentioned before, both private and public kind of healthcare companies will go to these tertiary markets, right? And still can be aligned with a credit tenant, right? Like you wouldn't typically buy an office building maybe in Harrisburg, Pennsylvania. Do you see that the opportunity in the life science sector will still be there in the tertiary markets, or do you feel like it will still be the concentration in kind of the main four?
I don't know that it'll be the main four, but I think there will continue to be life science clusters only because a lot of the tenants that are in these spaces tend to be, there's a lot of incubators where you need the venture capital that's in those areas and not as much in the tertiary markets. You need the like intellectual capital. A lot of these are around large institutions where you have research groups that are partnering with, whether it's, in the Boston area, you have quite a few different ones. We looked at an asset recently, in the New Haven, Yale area. There's, again, Philadelphia, there's a ton of intellectual capital coming out of, the center city, Philadelphia. So I think it will continue to be in larger markets. I don't know that it's going to stay as concentrated because I think it's, again, an area that everyone is wanting to expand into and is willing to put capital behind. But I think that given the large investment that it takes and the intellectual, basically you need the university talent coming out, research groups and teams. I think it'll be in larger markets for at least the foreseeable future.
Interesting. So Joe, as far as emerging markets or new opportunities, what are you guys looking at?
I guess to your the comment you just made, you're absolutely right. The secondary and tertiary markets are, sometimes an attractive investment, which is not what you might typically see in other asset classes. But you can find, for example, in a smaller market, middle of the country somewhere, it's not typically a target of the typical institutional capital, but you can find those scenarios where you have, similar to the way the life science cluster works that Caitlin is describing. You can find a credit profile in a smaller market where you have a health system or a dominant physician group, and they actually have kind of a stranglehold on their market and dominant market share, maybe the biggest or sometimes the only health system in a certain town. And if you can find an asset there that is important to their success and will continue to drive that dominant market position, it makes for an attractive investment. Even in the core category, it doesn't have to be one of the coastal cities or gateway markets or something like that. That's certainly an interesting characteristic for medical office, and it leads you to make investments all over the place. I think some of the emerging investments that we're seeing, the conversion play is a pretty popular approach, or at least attempted approach these days, where if somebody's got an office building with some vacancy in it and a couple of medical tenants, a dentist and a chiropractor or something, sometimes they think the whole thing can become a medical office building. That's not always a successful approach. The location is going to be critical. The fundamentals of the building are going to be critical. Sometimes it just doesn't support the type of infrastructure for a medical office build out. And a lot of the times you're seeing, rather than a repurpose of an old office building, health systems are looking at more retail type locations. Seen some really successful adaptation of mid-sized retail boxes that have gone vacant, and they're in a great location. They're visible, they're accessible, there's great parking. They're kind of tied to the patient's regular daily pattern of the grocery store or whatever. We're seeing that type of successful redevelopment occurring. It usually has to be driven by an anchor tenant in a health system that has identified that type of location, or a physician group that wants to be there. and it fits into their overall ambulatory healthcare footprint. Like in a lot of businesses, healthcare continues to consolidate, and there's kind of an arms race for new facilities. So the development side of the business is busy in a lot of places as health systems and providers try to increase their ambulatory footprint off campus. There's more investment occurring off campus than on in terms of new construction, certainly. So that's kind of continues to be an emerging and growing component of the overall sector. One other characteristic, I guess, is that the consolidation is occurring not only in health systems, but also in physician groups. And you're seeing, certain groups consolidate to grow in order to, be stronger, find some efficiencies with technology and electronic medical records and negotiating leverage with the payers. So that type of consolidation is occurring both in physician groups and health systems. And one of the things we've seen in the past 18 months is that the pandemic is a challenge. It's a challenge to delivering healthcare on a cost-effective basis and in scenarios where your accessibility might be curtailed. For example, a lot of elective surgeries were canceled, postponed just because of pandemic-related concerns. And that kind of increased the trend toward moving a lot of stuff off campus. The hospitals had to kind of shut down a lot of elective procedures, has a significant impact on their revenue and on their bottom line because they couldn't do them on campus and in more kind of confined or risky type locations. So you're seeing a lot of that being moved off campus, lower cost setting, more accessible, more controllable in a pandemic type situation, and a lot of partnership occurring between those larger growing physician groups and the health systems that are trying to find ways to succeed together in the same facilities.
Yeah, I mean, it's pretty similar to what we've seen, right? You've seen a lot of large health systems buying up various practices around the country. Certainly, their focus is always on patient care, right? And how to best do that. So I can understand the look at the retail, focus. How do you guys, or, I always get the question, do you look at, cold storage as a healthcare asset? Do you look at life science? I know, for public REITs like myself, we're really focused on clinical space. How do you guys look at, some of those other kind of quote unquote healthcare options?
Yeah, for us, life sciences is maybe an emerging target. We think there's, especially in kind of the academic affiliation, the health system affiliation, there's probably, there is a kind of a natural evolution for us into that type of life sciences investment that's a little more tied to, an academic medical center, a university, where those things tend to intersect. We think that's, consistent with our investment program and what our investors are looking for. We're not expanding into, pharmaceutical, for-profit, cold storage, interesting concept, but that's a little outside of our wheelhouse. But, generally, I think it's following similar investment patterns. We're not a participant there, but there's certainly more appetite and, it's becoming a larger and larger sector. And I know that pricing there and valuations have, especially in those key target clusters, those key geographies, valuations are approaching, pretty high levels, low cap rates.
Caitlin, is that what you're seeing as well? Have you seen, some of the peers in the healthcare expanding into life science and cold storage as other areas to expand their portfolios?
We haven't seen cold storage much, and quite honestly, I don't know if that's in our wheelhouse really either. But we have seen, we've talked a lot about, institutional investors coming in and liking the life science space, but, we have seen more traditional medical office investors transition into life science. It's not as often. I think it's definitely it fits very well with the strategy of the institutional investors, which is why we've seen more and more of them. But I think that it has started. We have seen some of our traditional medical office sponsors move into the life science space. It's definitely of high interest for everyone. And I think it's been kind of a hot topic for a while now. So I don't see that slowing down.
Sure.
I can quick comments on that too, Trent.
Yeah, go ahead.
I was just going to say, I mean, from a development perspective, we're definitely seeing parallels. I think Chris made this comment when we were planning for the call that some of the trends that we're seeing in life sciences are trends that were already happening. They're just being accelerated. That's very representative of cold storage and what you're seeing within industrial. But that's also really tied to, I guess, what I consider just an onshoring, or just what we're seeing as a lack of infrastructure to help support the needs for distribution of vaccines and things within the supply chain. And so a good example is that, a lot of the vaccines that are coming out right now for COVID, they have to be maintained at a certain temperature. Our supply chain is not set up to support that. And so there obviously is a cold storage component for that. I think what's maybe a little different between typical cold storage and maybe cold storage specifically for vaccines is that, there's likely going to be higher rents paid for storage of those vaccines because there's also more infrastructure needed. There's more FDA regulations for it. So we're tracking both, but we're seeing trends of high growth in both of those sectors because of the impact of COVID.
Chris, did you want to say something or?
Yeah, I think on the cold storage side, traditionally, so I come from a laboratory background back in the day, and Mayo Clinic has got a pretty robust set of infrastructure for cold storage, like robotic -80 freezers, right? So the kinds of freezers that can hold the kinds of things that we're shipping around the country these days. The difference between that and what is needed now is that in that kind of infrastructure, they go in and they rarely come out. Right, they're being collected from research studies from around the country, around the world, and they go in and they come out in dribs and drabs as research protocols are needed to access the plasma or the serum or the RNA or DNA or whatever's coming out. In this case, it's a rapid in and a rapid out because it's very transactional. The vaccines are coming in from the manufacturers, they have to get stored and they have to get distributed out. And the systems have to be rekeyed, I think, a little bit in order to support that more highly transactional sort of thing. But the needs are still there for that infrastructure, but it has to be operated a little bit differently. Brent mentioned the accelerating trends, trends that were taking place being accelerated. I think a lot of healthcare providers, we heard that in the first session with their telehealth initiatives. They reached their 2030 goals in 2020 just because of regulatory barriers being dropped, and it remains to be seen whether those barriers will stay low or if they're going to be raised up again. I think also in conversations we've had recently that there's some convergences that have been happening that we maybe weren't quite aware of, but we're much more aware of now because of COVID. And it's really a convergence of, you got around the country, you got biopharma hotspots, you've got med tech hotspots, you got tech AI hotspots, but the convergence of all of those around what's happening now has just been accelerated. That a convergence of biopharma, tech, meaning devices, wearable, digital, as well as the AI and the data mining that has to happen along that convergence really got accelerated over the last 10 months, and it's going to be hard to see going away from that. It's just going to continue to happen. So how do you bring those ecosystems together? How do you bring all those assets together and those players and those expertise together in what are oftentimes more disparate locations? How do you pull that all together then? Those expertise.
I guess I would be remiss. I mean, you brought up a good point. It wouldn't be a healthcare conference unless we talked about telehealth. Joe, I would love to get your thoughts on telehealth and the impact on the MOB space.
Mm-hmm. Yeah, it's really interesting. I think that it's been from what I've heard from certain tenants around the country, it's been a real important part of their success. There's even sometimes like their survival during the height of the pandemic, the ability to continue seeing patients virtually, to be able to bill and collect for that. There were certain exemptions made by CMS and other payers to allow that. And I think the consensus is that the COVID pandemic kind of accelerated the adoption and the installation, the rollout, whatever, of telehealth by 10 years or more. I think a lot of providers were anticipating that maybe by 2030 they'd reach a certain level of telehealth business, and they've hit that target already. It's been a real, clearly it's an efficient way to see patients for just regular checkups and lower acuity circumstances. It's really interesting. We think it's a really helpful part of the healthcare delivery process, and happy to see it grow. It's a way to shrink costs in the system and do things more efficiently. It's generally just a good thing for providers and patients. It creates a little bit of a question, a little bit of a challenge for the use of space in buildings, right? So as we're conceiving new buildings, programming new buildings, there's more of a attention being paid to where and how telehealth will be performed in that building. Both at primary care, specialists, radiology, that type of stuff. And it also raises a question of, the size of their clinical space. Do we need as many exam rooms in a primary care clinic because we've taken a certain percentage of our visits and made them virtual? Does the provider need to be in the office to conduct those, or can they do them from home? That's kind of an evolving target. And we don't think it's a threat really to, the durability of occupancy in most of our medical office buildings. There's exceptions to that. I think where we may see more of an adjustment or evolution among health systems, in particular hospitals and health systems, is the use of their administrative space. Like all of us, we've found that we've been able to be relatively productive and while working from home, and the same is true for administrative occupants in and around hospital campuses. And I know most providers, if not all of them, are kind of reevaluating that, just like all office users.
I think what remains to be seen yet, so the regulatory barriers, the reimbursement barriers to telehealth, they were dropped in response to COVID, so that those sorts of care opportunities were still available. It'll be interesting to see. It's going to be hard to put that genie back in the bottle in many ways, but there could be some snapback simply because, like, practicing across state lines, it was very difficult to do unless you were licensed in other states. And if bad actors show up, there could be some snapback on that. And so one hopes that doesn't happen, but it's always a possibility. But it's hard to imagine going back to what it was before. That telehealth now is not here to stay in a significant way.
I agree.
Yeah, at the end of last year, I was on the phone with the doctor, and we were talking about space needs and these things, and we started talking about telehealth, and one of his main points was that we're not at a point where it's going to completely take away the space. It might have issues on, like you said, administrative space and things, but ultimately they're going to still need to go see a doctor. And he said, until we have something where you can fully electrodes can read your entire body, right? We won't be there. But an important part of that is also the insurance companies that are backing the doctors, because doctors can be sued very easily for malpractice and other things. And so that's going to be an important part, not just the insurance companies as far as what the doctor can charge, but also the ones that insure the doctor, making medical diagnoses to patients over something like this. Caitlin, any thoughts on telehealth?
The one thing that we've heard pretty consistently too is, although I echo what everyone's saying here, that, there may be, different use of space, there maybe need to be some reconfigurations of space, but overall, we don't have a concern that space is going to, the need is going to decrease drastically, at least in the, in the near term. I think that this is, again, this has accelerated telehealth, but certain things you have to go in for. You can't have surgery via Zoom. you can't do certain things through the screen. So I think that over time we may see a shift. I don't think we anticipate that being anytime soon. And then the one thing that we've heard from quite a few people is that a lot of the telehealth services that are being offered are almost in addition to what already would have been offered, and that there's an ability to expand on services that they that they had in place today. And so it's not necessarily a replacement of of the use of medical office and a replacement of what was being done before, but adding to what docs are able to do, so, and the services they're able to provide. So I think that again, we don't have concerns in the near term, and it's not, we're not looking at it as something that we need to take too serious of a look at right now in terms of space. People decreasing their need for space. I think, again, it'll be a reconfiguration. There will be changes, but not an overall a drastic shift in requirements.
Sure. And Chris, what has kind of the work from home COVID era done to your side of the business?
So there's a lot of, in downtown Rochester, there's a lot of office space that is not being occupied right now. And the ripple effect therefore then, so let me back up a little bit. So the impact of COVID, patients stopped traveling immediately, and then they started coming back. And in Rochester at Mayo, patient visits are they're back to pretty much what they were pre-pandemic, and they've been back for quite a while. The distance that people are traveling to Rochester for their care is different. Fewer are flying, more are driving, and the international has disappeared. So for a period of time, there was a double whammy of patients weren't in Rochester, but then so many employees that weren't, frontline healthcare workers were working remote. So it was sort of a double whammy on the downtown market, so the retail, dining, entertainment businesses in Rochester. The patients have come back, but they're hesitant to come out of the healthcare setting in between appointments, and they go back to their room. But that's slowly starting to change. The vacated office space, that's going to be here for a little while, and we have to find creative ways to reuse that. Some of it may be conversion. I think in our case, many of the buildings, they're not as convertible to life sciences kinds of space, but finding ways to make that space attractive for startup companies as you invest in your startup ecosystem. There's opportunities there. For communities like ours, it's position yourself as, if you can work from anywhere, why not from here? And the quality of life, cost of living, what better place to live and work than next door to one of the premier healthcare organizations in the world, right? So that hospital-oriented development, I think, concept could be coming as a result of that. There's going to be a ripple effect for a while that we're going to have to deal with, though, with that vacated space.
We got a question from someone out there in Zoom land. It says, curious, what role can cities and states play to better support the advancement of life science hubs and clusters in creating the dynamic infrastructure to translate research and development into commercialization?
I'm happy to start, and maybe Chris, you can chime in. I think it's pretty representative of our experience in Rochester. And like I said in the beginning, that has really been a partnership with the EDA. And if it wasn't for the support of the EDA and the DMC funds, it's likely the first as well as the second phase for sure would have not started. And I think what's layered in that question too is that the reality is that a lot of the things and the investments that are being made in the DMC is more of a strategy around how do we secure the talent and how do we keep these companies here and support that ecosystem. And when you are competing for this type of talent, you have to have many reasons why a company should be within a certain location. Yes, it's great to be alongside certain research. Yes, it's great to be connected to a health system like Mayo Clinic, but a lot of these companies are looking for other incentives because many other states are doing that exact same thing. And so if specifically the state of Minnesota or other new states are considering investments into life sciences or helping support the research that's needed to support an ecosystem like what's happening in Rochester, it's a very critical component because it's typically sometimes, and Chris, you can speak to this more, a pretty early on request by some of these new companies that maybe they're not based in Minnesota, maybe they're not based in the United States, but it's very much so top of mind and very early conversations or considerations for new locations.
Yeah, we hear that. I think back to the original question, the public-private partnership approach, I think, is necessary. And that requires, on the public side of things, that requires a willingness and a will to engage in a public-private partnership, which isn't always there. I mean, if you look at the significant investment that Massachusetts has made in Boston over a significant period of time, and a tremendous amount of resources have gone into the Boston ecosystem over there. That took a degree of will and willingness over a long period of time to make that happen. And that's happened in other markets as well. And that's what's necessary. And getting in the public space, getting legislators to look at a 20-year time horizon isn't always the easiest thing. But that's what our legislation is, right? It drives what we do. It's a 20-year vision. And then it's the will to stick with that. So I think that will and willingness to engage in those public-private partnerships and take a long view and stay undeterred on that long view is really what's necessary. And that's not always easy to do when your funding is on a 2-year, when you're on a 2-year funding cycle at least in Minnesota, right? A 2-year budget cycle, and every 2 years you're looking at the budget again. That's not an easy thing to do.
Sure, and those politicians won't be in office in 20 years to seek the rewards, right?
Every legislative cycle, we have an education process that we want to go through just to make sure, both at the state and the local level, all of which is necessary. And it does cause some course corrections along the way, almost inevitably, but you try to keep that to a minimum so you can keep your eye on the long range vision.
Great. Well, I think we're just about there on time, unless anybody wants to give a final thought on their sector. All good? Todd, do we have any questions or anything that have come in?
Got one for you. If you were going to put money in the healthcare sector to invest, I've got a friend right now looking to invest multiple millions, retirement age, where would you go? Cold storage? I know you all poo-pooed that. MOB, retail, moving into retail sector. What do you do? What do you do with your money?
GameStop.
Joe, you want to go first? GameStop.
GameStop. I shorted GameStop this week, just for the record. It's not going well for me.
Bitcoin?
A good MOB deal or a life sciences deal, you're probably in pretty good shape.
Life sciences, you're probably chasing yield, a little bit lower yield, but long-term opportunity.
Yeah,
I think that's correct.
And I think both of those sectors, right? The thing there is the stickiness of the tenant, right? And the fact that a lot of these tenants will invest a significant amount of their own money into your building will create a sticky situation for them, and could be a very good long-term play for you.
So don't foot the TI bill. Make the tenants come to the table.
If you can get away with that, but I'm sure you're going to have to throw some dollars at it.
Right. Well, great. Thanks here, everybody. What a great event. Love all the smiles. It's great to see you all. I can't wait to do this live. Well, our national events aren't meant to be live, but I know a lot of you are in markets where we do events, and I'm excited to get back out there. All of you in the healthcare industry, keep giving those shots out. I heard 130 million people will be vaccinated by the end of March. Sounds like us as an industry can maybe start getting back together soon. Well, but thank you, everybody. Wonderful event. Any comments or questions in the future? You probably got an email from me, Alyssa Galinsky, our event producer, or Jay Cody Tech, who put this event together. Any of those people can help you out. This will go on YouTube at some point. However, we are creating our own Vimeo channel that'll be on our website. So hopefully look for all those things soon. You are a YouTube superstar now. You can tell your children, friends, and family. Thanks, everybody. Have a wonderful afternoon. Happy Wednesday. And
Thanks, guys.
Thanks, everyone.
Bye.
I love the wave, the Zoom wave. I'm all in, Brent Webb. Just, it might sound cheesy, but there's just not much else you can do.